Hello, doctors. Today we are going to study about miscarriages, an important topic in obstetrics and gynecology. So, we'll go through the definition, causes, and types of miscarriages, the clinical features, investigations, and finally the OPD and IPD management. And in today's session, and always remember, miscarriages are not just a physical problem; they also carry a major emotional impact for the patient. So let's move towards the topic today. First, we'll do a brief discussion on today's session introduction. So, miscarriage, talking about the definition, it is a spontaneous loss of pregnancy before 20 weeks gestation. So, miscarriage is defined as the spontaneous loss of pregnancy before 20 weeks of gestation. It is also called as a spontaneous abortion. Clinically, like when the growth of the gestation, if it is if the pregnancy, if the patient lost the fetus before the 20 weeks of gestation, that is what in a simple language we can tell miscarriage. So clinically, so it is also called a spontaneous abortion, and clinically there are different types. There are like threatened abortion, or we can call inevitable, incomplete abortion, complete abortion, missed abortion, recurrent abortions, and all. So this condition is one of the most common complications of pregnancy and is associated with both maternal morbidity and psychological distress also. So as a clinicians, our role is not only diagnosis and management but also the counseling and reassurance. So this is what the important point in the introduction we saw now. Definition, the types of abortions or miscarriages, and the important cause of, and the important point is that it is the important cause of maternal morbidity and psychological stress. So this is the basic intro of miscarriage. Moving on to the epidemiology. So miscarriages are actually very common. So about 10 to 15 percentage of clinically recognized pregnancies end in miscarriages. And if we include very early losses before women even know they are pregnant, the percentage is much higher. So the risk increases with maternal age and with a history of previous miscarriages, and most miscarriages occur in the first trimester before the 12 weeks. So whenever a pregnant woman present with bleeding in early pregnancy, always think about miscarriage in your differential diagnosis. Okay, so most occur, also it occurs in the 10 to 15 percentage of clinically recognized pregnancies. Risk increases with maternal age and previous miscarriages, and most of the time it occurred before the 12 weeks of gestation. So this is the epidemiology of miscarriages. Moving on to the etiology and risk factors. So let us look at the causes of miscarriage. The most common cause is chromosomal abnormalities. That is the most common in the fetus. So this accounts for about half of early miscarriages. And other causes are maternal, such as uncontrolled diabetes, thyroid disorders, and infections. That is the maternal factors. And there can be because of the structural causes, which include uterine anomalies or cervical incompetence and all. Lifestyle factors like smoking, alcohol, obesity are well documented risk here. And finally, the immunological risk causes like antiphospholipid antibody syndrome. It plays a very important role in recurrent miscarriages. So these are the few etiology and risk factors of miscarriage. So when you evaluate a patient, always keep both fetal and maternal factors in mind. So there can be, maybe because of the maternal factors, they can lead to it can lead to miscarriages. It may be because of the anatomical or structural changes, or maybe because of the chromosomal abnormalities, or the immunological changes, or lifestyle things. So always keep a mind of fetal and maternal factors in mind before treating the when you evaluate a patient regarding the miscarriages or repeated abortions. Moving on to the types of miscarriages. There are several types we need to recognize. Like as I've mentioned in the first slide, there are threatened, inevitable, incomplete, complete, missed, and recurrent miscarriages, which can be greater than equal to three consecutive losses. So, threatened abortion or threatened miscarriage is bleeding, but there will be bleeding, but cervix will be closed. Pregnancy is still viable. That is threatened miscarriage. Inevitable miscarriage, the cervix will be open, miscarriage cannot be stopped. Incomplete miscarriages, some products have been expelled, but some will be remained in the uterus. Complete miscarriages, everything is expelled, uterus will be empty. Missed miscarriage means embryo or fetus is dead, but it is retained in the uterus. It have not come out. And the recurrent miscarriage is three when there is three or more consecutive losses. So that is a recurrent miscarriage. So these are the types of miscarriages, and these types are very important because management differs in each case. So in each of the type of miscarriages, so always all the treatment for miscarriage is not same for all type of miscarriages. So each have a different types of treatments and medications you have to give. So that is one of the types of miscarriages we are when we are treating, we have to know what are the types of miscarriages. So it is very important to differentiate the conditions when what the patient is have experienced or is going through. Moving on to the clinical features. So the most common symptom is vaginal bleeding. That is the most commonest symptom the patient experience in the clinical features. The first clinical feature when the patient is having a miscarriage, first symptom is vaginal bleeding. This may vary. There can be like a spotting or a heavy bleeding with the clots. So there can be different types of, maybe sometimes a spotting the patient may see, or maybe a heavy bleeding with clots. And there can be abdominal or pelvic pain, abdominal cramping or pelvic pain the patient may experience. And the patient may also report a kind of a passage of tissue. So, in missed miscarriages, as I have mentioned before, in missed miscarriages, the woman may notice a loss of pregnancy symptoms such as nausea or breast tenderness. So, a loss of pregnancy symptoms in case of missed miscarriage and passage of tissue. Sometimes the patient may see something have expelled out from the uterus. So that is these are the clinical important clinical features the patient may experience during the miscarriage. So whenever you see a bleeding in pregnancy, always correlate with the pain and cervical findings. So that is important regarding the clinical features of miscarriages. Moving on to the investigation. So, what are the investigations you can do when the patient complains of miscarriage? So, in all suspected miscarriages, we must confirm the diagnosis. So, first thing you have to do is clinical examination. So, clinical examination is the first step we'll do. Check the vitals. You have to do abdominal examination, speculum, and bimanual exam. So that is a clinical examination you have to do. And always before doing this clinical examination, you have to do ask about the history, about the gestation period, and all the medical history of the patient, previous miscarriages or anything. So always history is very important. After that, the first important thing you have to do is clinical examination. Next comes the ultrasound. So ultrasound is the most important tool which will tell us about the fetal viability and whether the products are retained or not. Like if there is any parts are remained in the uterus and few have expelled. So that will we can see in the ultrasound examination. Next is the serum beta HCG level. So while checking the serum beta HCG, which can help especially if the viability is uncertain. So that you can do in investigation. And other blood tests like CBC are important to assess the blood loss. And in recurrent miscarriages, we check the thyroid profile, blood sugar level, and torch if recurrent, torch infection. And even karyotyping of parents and products also can be done. Karyotyping in recurrent miscarriage is also you can see, you can do the karyotyping when the patient have a history of recurrent miscarriages. So investigation will help us differentiate the type of miscarriages, and we can do the treatment or management plan accordingly. So that is very important part of miscarriage. Investigation part is very important when the patient comes to you with the complaint of miscarriage or abortion. So how we can treat in the OPD versus OPD management and the IPD management. So how you can treat the patient in OPD basis and IPD basis. First thing, in OPD management, always we usually deal with the threatened miscarriages. So these women have bleeding but pregnant, but there are chances of pregnancy because pregnancy is still viable. And so in these cases you can do OPD management. So in threatened miscarriages, uh, in these conditions, the treatment is mainly supportive treatment. So you can reassure, you can give reassurance and bed rest, or reduced, you can advise them to avoid any exertion. And you can also give progesterone supplementation in selected cases, analgesics for pain relief, regular follow up with ultrasound to ensure pregnancy is progressing, and most importantly, and then the next one is the counseling and psychological support is also should be given in the OPD management, because patient will be worried about whether the pregnancy is still viable or not. So they'll be having many questions around their mind. So you have to always counsel the patient and give a psychological support regarding it, and regular follow up with the ultrasound to ensure pregnancy is progressing. So that is the most important thing. And as I've mentioned, most important, psychological support. Many patients, as I've mentioned, may be very anxious, so clear counseling is very essential. And you can always follow up the patient with ultrasound for viable pregnancy, if viable pregnancy is there present. So that is how you can do the management of the condition in the OPD basis. Moving on to the IPD management. So how you can treat the patient in the IPD basis. So in IPD settings, we manage the more serious cases, like for example, inevitable miscarriage, or incomplete miscarriage, or septic miscarriage. So these conditions, so these types of miscarriages we mostly treat in the IPD level. So we have to admit the patient. So the priorities here we are doing is, first thing, stabilize the patient, IV fluids, blood transfusion if required, antibiotics if infection is suspected. So these are the stabilize. This is how you have to do, so stabilize the patient. Second thing is evacuate the uterus. So this can be medical, using a misoprostol, or surgical and using manual vacuum aspiration, or DNC. Manual vacuum MVA or DNC, with, or surgically you can do that, or medically you can advise misoprostol. So this is how you have to evacuate the uterus, because if there is, in case of inevitable or incomplete pregnancy, there can be sometimes the parts or something will be will not be completely expelled, it will be present in the uterus, so you have to evacuate it. Third is uh, monitor the patient. So monitor the patient closely after evacuation for any bleeding, and you have to monitor the vitals of the patient, and check the patient for the signs of any infection. So and one more thing is blood transfusion. If there is severe bleeding, you can go for blood transfusion only if it is required, and only if it is if there is severe bleeding present, then you can go for a blood transfusion. Then as I've mentioned, post evacuation monitoring and counseling. So always provide a counseling, not only when the patient is admitted and getting the treatment done, or in the OPD basis also. Always provide proper counseling and discuss the contraception and preconception care for future pregnancies. So this is most important thing when treating a patient in OPD versus IPD or IPD level. Counseling and psychological support and mental support should be given to the patient while managing the condition in OPD and IPD. Moving on to the complications. So as I've mentioned, miscarriages can lead to complication, especially if it is not managed well. hemorrhage and shock are like acute emergencies. Infection, septic abortion, it will remains important, particularly in the case of unsafe abortions. Repeated curettage may cause Asherman's syndrome, or intrauterine adhesions. So there is also psychological trauma that patients and families go through, and of course recurrent miscarriage may later cause infertility. So prevention and good care are key to reducing the complications. So this is the complications of miscarriages, which can lead complications which where the miscarriage can leads to, especially if it is not managed well. Moving on to the prevention and counseling. So, how do we prevent miscarriages, and about the counseling? First thing is preconception counseling, and is very important. So, preconception counseling is very important because it will help to control diabetes, thyroid disease, and other, if there is any other chronic conditions before any before conception. So preconception counseling is very important, and also the control of medical conditions. So if the patient is diabetic, or if she is having thyroid disorders and all, that should be under control. Next is folic acid. Folic acid supplementation. So folic acid and preconception supplementations can be given. You can advise it, and ask the patients if they have a history of smoking, alcohol, and obesity. Ask the patient to avoid smoking, any kind of smoking or alcohol consumption, and obesity also. Counseling regarding obesity can also be given to the patient. Next is the early antenatal booking and monitoring. So encourage patients to have a early antenatal booking and regular monitoring of the antenatal things, and most importantly provide emotional and psychological support after a miscarriage. So remember, not only to the patient, but with the family also. So remember, counseling the couple is very important as a medical management. So very important to counsel and give a psychological support for the couples, for the patient, and as well as the family, because not only through the medications, with the proper counseling but the counseling is also very important. So both in hand. So that is how we can do the prevention counseling to the patients. Moving on to the summary of today's session. So to summarize today's lecture, miscarriage, as I have mentioned, it is spontaneous pregnancy loss before the 20 weeks or 20 weeks gestation, and the causes I have mentioned, it can cause due to chromosomal or maternal factors, anatomical structural or structural deformities or structural factors, lifestyle or immunological, and clinically, the main symptom is bleeding with or without pain, and there can be passage of tissue also. And ultrasound is the key investigation in this, and you can go for beta HCG and other lab investigations. Coming to the management, OPD management is supportive in threatened miscarriage, and IPD management is supportive in the incomplete or sepsis or inevitable miscarriages and all. So in IPD management, as we have discussed, it involves stabilization of the patient and evacuation in missed, inevitable, incomplete, or septic pregnancy or septic cases, in septic abortions. So prevention is through the preconception care, lifestyle modification, counseling the patient. So this is the important things we have discussed in today's topic. So be vigilant, act promptly, and always combine medical care with proper counseling. So this comes to the end of our today's topic, today's lecture. Thank you. So this is the end of today's lecture. I hope you got a clear idea of the miscarriage and types of miscarriage and all. Thank you so much, and have a nice day.